I'm grateful at times for doctors reaching out and asking questions. This is something I did often when I began doing cases that were more and more challenging. This is a case that on the outside may seem like a straightforward case. For those who've done a bunch of all-on-4 surgeries, they would probably really quickly identify some things that concern them. And so I want to just walk through how I would see this case and what I would do, how I'd handle it. Now, I have not met this patient. This is a friend of mine and one of the doctors come out and we've done some mentoring together and asked for my suggestions on it and how I'd approach it. And so I have not seen this patient. I'm just looking at two-dimensional pictures, and I'll explain kind of what I can see from here, and I'll also identify what I can't see and what I wish I had access to be able to know more about it. But let's talk about this. When we're looking at doing all-on-4 treatment, there's a couple things that are really critical when identifying which patients are good candidates. Right away, as this patient smiles, I think right away, okay, what sticks out to me is that we have a patient that has a gummy smile. So a gummy smile is not a bad thing. I have actually a gummy smile, but when you're doing all-on-4, it can be a really serious problem because anything that you see in the gum. So I'll draw on this picture and show you how I look at it. Maybe I should go with that color. As I look at this case, all of this is kind of thick. So all of this above here is gums. Okay, you can see that she shows that. And this should be a picture taken with a patient when she's smiling high. I don't believe this is actually as high as she can go. If this was, it still is a hard case, but I actually think that more than likely her lip is going to even raise higher than this. When we have a high smile line when it comes to all-on-4, the problems that we face with it is that one of the critical things we must do is we have to take out the teeth. So all these teeth come out, okay? And then in between the teeth, we have this bone that comes up. We have to shave down that bone so the bone is flat, okay? And our bridge is gonna come and sit on top of here. And so what's important is that if let's say this is our bridge, comes through here, and if we can see the top of that bridge, then it's not gonna look natural. So so what determines how far we have to reduce is what's the high smile line. So if this is a patient that does have a high smile line or gummy smile, that means the lips are being pulled up higher than normal. Usually lips are probably more closer to here, okay? And that's their average. And so we need to make sure that our implants go in, one here, one here, one here, and one back here, that these implants are going to go in, and that the bridge that we connect to them has to be, the top of that bridge has to be above the lips. If not, that transition line will show, okay? Well, that's why I have this x-ray over here. When we look over here, this white line that I'm outlining here, that is the sinus. So that sinus, if we look at the level of her teeth here, and we look here, you can see that we definitely have to go up higher than that. So we need to be up in this area, right? So we have to reduce bone least to that. That would be just to barely cover it. Now, if we drew that line all the way back, do you see how close we're getting to the sinuses? So oftentimes, like let's say we have to go to here or up here, if we take that back and reduce that bone back, now we actually would be unroofing the sinus. So that's one thing that makes this case difficult as well, is that she has a gummy smile, extra bone reduction, and her sinuses are low. So gummy smile, low sinuses, and so that's a big deal. Now the other thing that I look at this, if we so the doctor asked what, how would I approach it? He mentioned, he talked about, would we change the vertical dimension? Because if this is where her teeth are right now, if we took the teeth and went upward and then let that chin move upward as well, then that would be a decrease in the vertical dimension. And I don't like to do that for a couple reasons. So when the chin or the jaw moves upward in this area, it's going to move upward and it's going to move outward. So this makes it so the jaw is more prone. It's basically more like witch-like. Most women and people don't like that look. But on top of it, it'll make it so if the lower jaw is going to come out more, meaning it's going to be farther forward, that means we have to take the upper teeth out as well, right? We can't have lower teeth that would, that would be out further than upper teeth. The upper teeth need to overlap or at least be even with the lower teeth. So if she already has a high, has a smile that's really gummy, and we have to move the top teeth out a little bit to accommodate that, now it's going to accentuate the smile. It's going to accentuate that high pull. And so that's not a good thing in this case. And so I don't recommend closing the vertical or decreasing the vertical dimension. My recommendation would be to keep the vertical dimension exactly the same. And the vertical dimension basically means is that, if we were to measure from this nose down to the chin, that this stays constant. That's the space we have to work with. When we close or when we open a vertical dimension, we actually drop the chin down. Okay. If we close the vertical dimension, now we're actually going to bring the chin, this part here, and move it up with the teeth. That's closing it. But again, like I told you, when you go up, then the chin is going to move out, which means the top is going to have to be adjusted as well. So that means that we are going to keep this distance between the nose and the chin the same. That means that the bone that goes through here and everything is that we're not going to move where the chin goes. But what we can do, and this is what I recommend, is we want to be able to put teeth in that, so we can redistribute this distance. So this distance here, we call it a window. Right now, the teeth here are taking up maybe 85% of that window. Okay. As we go backwards, it changes. Now that, we look here, the amount of space here is taking up is still extreme. The top is taking up more than the bottom. But over here, now this looks more like we would want it to be. So what we need to do, if we keep all things equal, what we need to do, all things equal, meaning that we're not changing that vertical dimension. We just want to change the distribution. Instead of 80% upper teeth and, or 90% upper teeth and 10% lower teeth, we want to change that. So now we're going to take this edge and we're going to move it upward to somewhere in here. Okay. And then what that means is that we're going to increase the edge of the lower to go up as well. So we're maintaining the vertical dimension. We're really just changing the occlusal plane. Right? Instead of that plane being between them being here, we're going to basically bring it up to here. And so the teeth will still meet in the middle. And this can be confusing for some people, especially patients, but even for doctors, that what we're basically doing is, if you think it from here, if this stays constant, the top stays constant, we're not moving anything. All we're doing, in a sense, is saying, okay, I'm going to move this tooth. We're going to cut this tooth down, in a sense, and go upward. And we're going to add tooth to this. We're not changing anything. It's almost like we're just cutting off here and putting it onto there. Okay? So we maintain the vertical dimension, we redistribute the proportions, and there's a little bit of overlap there also. I don't know how much. It's hard to see in this, given the information. I don't have a third dimension to tell how much overlap. But even if you had to go more end to end to make that happen, that's okay. But the other thing I think will make a big difference for this patient cosmetically is if we start here. First of all, it's pretty clear to me that this midline, gosh darn it, current midline here is off. You can see her nose is here, midline is here, right? So we do have a midline that's off, so we want to change that. But the biggest thing I notice here is that the distance between the canines, this space is really small. It really should be, we have more room. Usually the sides of the nose are going to give us, an idea of where we want the teeth to be, the front six. Because these two front, of course, working right downtown, this is what happens sometimes, making a video. But let's say we were keeping this midline just to help get an idea of what we're talking. The midline does actually go to the patient's right too, it looks like. But let's say it's here. Now we want to make that front one wider, which will make this like that, and this like this. So that the two front teeth must be much bigger. And when you make those bigger, you're going to see is that you can make it so they don't, now this is going to change the proportions here. Like that. So we make bigger teeth, if I was to say it in a simple way. The teeth need to be wider. The teeth need to be wider. We need to take them up, and then the lowers do the same thing. We go up. If anything, something that can help, but it can be harder for patients to speak. I don't know what like in that third direction is if the teeth are tilted out, if we tilted them in and corrected that, if that's what the way they were, that would make it so the lip doesn't show as much as well. To me, the lower, this down here, the lip looks a little bit dominant. And so if anything, I would, tilt these teeth in a little bit, and it would make it so this lower smile, or this lower lip doesn't bow out so much. I think it just looks like it's, maybe these teeth are being tilted out a little bit more than they need to be. And so if we can tilt these lower teeth inward, it would allow these upper teeth to be pulled in just a little bit. And that will also make it so that this smile window is smaller. And the reason that is because if you really take it down to something really basic, the window, or the lip here is just like a big drape. And it's like if you're behind the drape and you move, if you move it out, you'll see that this window starts to go up. If you go backward, the window starts to fall, the drape falls. And so that's a confusing concept, but my comment here is, when you deal with gummy smiles, we're looking at, yes, we want to change maybe the length of the tooth, we want to change the width of the tooth and how long the tooth is, but we can also change where the teeth are, because the lip is holding up the smile. So if we move this smile inward in a sense, and it doesn't change the phonetics or the talking too much, or the patient's willing to do that and adapt to it, some patients are, then it will make it so you have less of a gummy smile. But if I was to review this case and just kind of sum it up, we have to be careful with these sinuses because they are low. So if you are going to do reduction here, you be careful that you may get into the sinus. Better to move that sinus or do a graft, or we call a sinus crush, where we actually push the sinus up so that it gives you more room to do that. This implant here can be tricky, in this implant here, because you're going to want to be right up against the sinus. Sometimes when you're putting it right against the sinus, that head sometimes can slip in the sinus, and it can actually get lost. Not lost, but it gets trapped inside the sinus area, and then you have to go and open up a window and go retrieve it. Not something you want to do, and it takes some time. But because you're so close to the sinus, in order to give it the right spread, that is a risk. So bone quality is important too. It looks like that she has soft bone back here around these teeth. So I think that, I got to be careful of that as well. You know, at the end of the day, I do think that the vertical is good. I do think that these teeth here in the front, lower front, because of the way they are more likely they've erupted up into it, and so that's why I think that this case will land on its feet if there's just really good planning. But I hope that's helpful. I think that this is a great case. It's not a case I would take on if I was a new doctor doing All-on-4, but if the patient's the right type of patient, and always make sure that they're cleared for surgery, that they have a good bill of health, that they're not an uncontrolled diabetic, they're not a heavy smoker, that they are not on so many medications that their body wouldn't react correctly. As we look at this patient, we don't have a medical history in front of me, but I would say that her, she does have makeup on, and it can be sometimes misleading, but nothing jumps out. Her gums do look a little bit dark. That can be just genetic, but sometimes it can be an indication of something, and so you would think that also in your workup and diagnosis. But it's definitely a challenging case. Now, one last thing I want to tell you is that it's how I would manage this case is that I would load the bite, take a bite, load bite. So scan teeth, and bite, and that bite is the correct vertical. We don't change that. Then when we bring it into our software, we're gonna take the bite, and then we're going to change the smile, but we're gonna maintain that vertical, meaning that we will adjust. We will design teeth that where they are wider and they come up and they fill the space more, and we will also, if we have to, adjust the lowers up, and so I would do that before the surgery started, and then during the surgery we would take records of implant positions, and then those implant positions would be adapted into the design of my new teeth, and then I would print or mill a set of temporaries for the patient to wear at least for a week, maybe up to 4 months, for the patient to have a chance to wear them. And that would allow the lips to adjust, the person for this lady to be able to speak and see if the speech is going to work itself out as well. Sometimes I see it like if you're playing football, right? And you're trying to score a touchdown, in temporaries you can get right to like the 90-yard line if you really know where what the patient wants. If you're really clear, if the patient doesn't know, or you're doing extreme changes that they're not sure about, then what can happen is you may be playing the ball to this 90-yard line, but not realizing that a patient sees the game this way, and actually the touchdown, you were headed this direction, but you needed to go this direction. And this is why I'm a big advocate of the patient and the doctor seeing something in the mouth before they go into the finals. 24-hour teeth is not something that I endorse, and I think it's hasty. Oftentimes patients will end up with inferior designs and not know them for years down the road. And then when problems arise, it's too late to make those changes. Their doctor's no longer in that office anymore. It's a new doctor, and now they're dealing with a whole new office, and they don't want to do anything without extra expenses. And so always request that even if you're doing it in a shortened time, it's okay. I do cases at times where I'm doing from beginning to end in 7 to 10 days on individuals that I've cleared for this unique experience, where I'm basically taking them through a process of really discovering during that time. But I definitely wouldn't take them from beginning to end in 24 hours without getting some clarity on it, especially on a patient like this, where you want to make some big changes, some really positive changes. The chance of you landing in a place where you're in this end zone and not, in this end zone, or maybe the end zone is over here and it's like this. Sometimes you don't know. But what I do know is this is patients do appreciate when you take the time to get to know them, what their desires are. And if nothing else, if you're a doctor like me that feels like they know what they want in the smile, I'll let them know early on, this is where I like to take it, this is where I see it. And if you can't agree that that's the direction you want to head, because I'll be honest, there's times when I don't want to take, may not like this end zone. And I'm like, you know what, if that's the direction you want, if you want that type of smile or that type of design, or maybe it's the treatment timeline, or it could be a number of different things, meaning that we're just not aligned up. My north, south, east, east, west is different than theirs. That's okay. That's just fine. That's a blessing that we figure that out early on. Either I tell patients, look at my smiles, watch my videos. If you like the smiles I give, trust me. I want your opinion, but give me the liberty of giving you the very best smile. If you get too involved in the smile and you start to tell me how to be an artist, then sometimes that can create an outcome that is not desirable, and not enjoyable for the person that's doing it for you as well. And sometimes I've had patients early on in my career where I wasn't clear about this, and I let them kind of guide me in a place I didn't want to be, only to have to redo everything after they realized I was right. And that's why as doctors go to school for so long. Someone that really can see aesthetics really well, and it's their life, it becomes easy for them to identify, okay, I need to move the midline, I need to shorten this tooth, increase the zenith width, I need to keep the vertical the same way, I need to watch out for the sinus. Within seconds of looking at this material, I already had a design in my head that now I had to create that in a design software. But it takes a lot of trust, and if there's no trust there in that relationship, sometimes the trust can be because you've seen other cases, you've seen other patients, you've seen lots of live videos. But if you start off without trust, that's not a good place to be. And I highly recommend you find someone that you feel like you can trust, and you give them the benefit of doubt. And so, as a doctor, what we can learn here is be careful with the cases you take. Sometimes our best intentions don't end up with good outcomes, or they don't end up with touchdowns. I could say that. And I might think we hit a touchdown, but sometimes we went out of bounds, and patients aren't happy, and doctors not happy, and team's not happy, and the doctor's wife's not happy. And you don't want that, right? So do your homework, get clear about what you want, get the right doctor, find the right patient, make sure you're aligned with the right patient if you're the doctor. And I hope this is helpful. This has been good little cases review.